It's 8:30, so I'm going to go ahead and get started. Can everyone hear me okay? It's not a real big room. Let me just double check that we're recording. We are. So I'll apologize for the early introduction to statistics. I know it's a Friday and there's a lot of other things that you'd probably rather be doing, but I appreciate you all coming out and showing interest in learning more about this, because I have a feeling that you're going to be using a lot of it, if not producing it yourself, at least talking to statisticians about some of the stuff that you're going to learn today in your own research. So this is an introduction to biostatistics for researchers, clinical and translational researchers. It's sponsored by the University of Kansas Medical Center Department of Biostatistics, the Cancer Center here, as well as the CTSA Frontiers Heartland Institute for Clinical and Translational Research. So I hope that you all find benefit from this course. I hope that I don't put you to sleep. I hope that you ask questions over anything. If I use an acronym, or if I'm not speaking clearly enough, or if you can't hear me, I feel like I'm not very loud. Please, I want this to be more of an interactive session than me standing up here droning on for 2 hours about statistics and putting you to sleep. My name, first off, is Jo Wick. I have my PhD in statistics from Baylor University, and I've been here since 2008. If you try to find the Department of Biostatistics, you just go back to Robinson Elevator and go straight up to the 5th floor. Step off and you'll see our sign on the door. So that's where all the statisticians are housed on this campus. Feel free to email me if you have any specific questions about your project, or if you have any follow-up suggestions about this course. For the future, and if you want to review any of these concepts, we are recording the lectures and posting them on our department website. And it's really easy to remember, biostatistics.kumc.edu. On the left-hand side, you'll see events and lectures, and then it'll take you to a link so you can go back and view these recordings. So just to clarify the objectives for today and for the remaining 3 lectures in this series, I'm not trying to make you statisticians, but I'm trying to teach you the language and the fundamental underlying concepts of statistics. So I know when I talk to researchers or people who are interested in doing some kind of statistical test, usually their questions are one of 2 things. Number 1, which test do I use? Number 2, how many subjects or samples do I need? So we're going to cover those 2 things pretty thoroughly. At the end of this course, I think in your mind you're going to be able to visualize, number 1, what are the things I need to know to determine how many subjects I need? And number 2, what are the things that I need to know to figure out which test I need to use? Actually, there's a third one. When do I need to actually just go talk to a statistician and not do this myself? So a couple of overall kind of vague but broad course objectives. I want you to understand the role statistics plays in the scientific process in general, and how it is a core component or a key feature of evidence-based medicine. So we'll actually define evidence-based medicine. And you can take out the word medicine here. Evidence-based anything. Practice in whatever your field is. Understand the features, strengths, and limitation of the different types of studies that you can do. Descriptive studies, observational studies, and true experiments. So we're going to define those different types of studies, show you where the different specific scenarios could fall, and then what are their strengths and limitations. We're going to talk about interpretation, which are the last 2 here. So whenever you're reading the literature or you're trying to write up your own results and disseminate them, you have to be careful that you understand, number 1, what kind of study you actually did, and number 2, what your results actually mean. So did you show an association between 2 things? Or was it truly a cause and effect relationship? Do you really understand the roles that bias and chance and confounding have, number 1, in your study, number 2, in the studies that you're reading in the literature? So teaching you sort of how to critically evaluate your own work as well as the work that other people are publishing. Today, we're going to do a vocabulary lesson. Remind you of all the things that you probably heard before or maybe didn't hear clearly before or didn't understand fully, because we can't jump right into hypothesis testing or sample size calculations without laying the groundwork of the vocabulary. So today we're going to talk about some core concepts in statistics. We're going to talk about the resources available to you. And then in the next 3 lectures, which are same time, same place, the next 3 Fridays, we'll really get into those specific questions that you guys have, which is, what test do I use? How many subjects do I need? And what does this particular method that I'm reading over and over and over in the literature actually mean? Why are they using it? So quality of evidence, which will be more design of experiments and evaluating the literature, hypothesis testing, application of the concepts we talk about here to common questions that we get in clinical research, and then more hypothesis testing, more questions that you see over and over in the literature. Before I get into my part of the talk, our, oh my gosh, I forgot your title again, Director of Research IT for the Department of Biostatistics is going to get up and speak to you a little bit about the resources available to you all as researchers on this campus. So here you go, Dinesh.
Thank you, Joe. Good morning, everyone. So Joe mentioned that there are 2 important points for the clinical trial. That is, what's the sample size, what test we need to do, but at the same time, there is a sample size. So in order to collect the sample, we need to collect the data. So for every clinical trial, we need to have a system which can collect the data and which can also generate reports or give back that data to the statistician so that they can run their test and come up with a final result. So as Joe mentioned, Biostatistics department, if you just go in there, the first step is to register your project. So you find a registration page right here. We ask everyone to register their project because we have different statisticians who specialize in different areas. Say for suppose cancer, we have Brooke, we have Devin, and people, every statistician specializes in different categories. So we request everyone to register their project first, and then also we would like to know what exactly you're expecting us to do. Say for suppose we can do data management for you, we can do all kinds of things with respect to the clinical trials. So the next step, as soon as you register, it's going to send out an email to our project manager, Megan Parks, and she will contact you through an email and set up a meeting with the actual statistician, and then they'll go through that. And even there are different scenarios where you got to talk to the statistician. Upfront, when you're trying to come up with a new protocol or new grant or new project, then the statistician is going to help you out in deciding what's the sample size and what kind of test you can use. And then also, once the project is going well, I mean after the project has been started, every 3 months we might be running DSMB reports for you, we might be doing quality control on the data, things like that. And in order to do that, we have the tool called CRIS. We call this as e-research also. It's like the EMR, like electronic medical record, but it's like for research. So I'm just going to quickly show the tool over here. This is how the tool is going to look like once you log in. This is the clinical, it is also called a CTMS tool, Clinical Trial Management System, which can do various stuff. There are a lot of tools out there which are electronic data capture tool, But how different this is, it's different because it has got all the features to do a real clinical trial management. When I say that, the features are mainly the standard forms. We got the standard forms, so we do not have to waste time deciding what variables you need to capture for your clinical trial. So we already have the template. So the PI comes in and just looks at the existing forms, and they just pick what variable they need to capture for their specific trial. And we have ad hoc and custom reports. Custom reports are something which we do specific to the trial or specific to the study. And in the same category, we have DSMB reports. We can have jobs running, which will just show the total number of patients that have been accrued for the study. And study calendars. Calendars are more helpful to schedule the patients who are on the study to come in at a particular time and try to be part of the study. Financial module is something that is more for administration stuff, who's sponsoring the study, who's sponsoring the trial and the grant, and all those stuff could be done with the same tool. Randomization is something new which we implemented recently. So the tool can automatically randomize a patient and assign the patient to whichever arm it needs to go. There are a lot of pharma studies that are here that are done, and so they actually try to have like multiple drugs, and they're trying to see which drug is better for a particular case, like say for suppose cancer or for any pain. So in that particular situation, patients are randomized to different drugs, and they are on different drugs. So for that purpose, the randomization is really used. And in any case, like we are there to help to smoothly carry the trial and capture the data and play with the data. And also we have a lot of statisticians. When I say statisticians, they're statisticians who can massage the data depending upon how we want the data to look like at the end of the trial to get the exact results. So that's some, just like a brief introduction to our tool. I can take any questions just related to the tool.
You can always follow up with Dinesh
Yep.
if you are thinking of utilizing
The tool.
the tools that he spoke about, or if you need any more information about project registration. So just to follow up on what he was talking about, if you have a project but you don't have any money, but you do need to consult with a statistician, please go ahead and register your project, because you get a free initial consultation where we can kind of put you in the push you in the right direction toward the resources that you need, or the methods, or funding opportunities and things like that. So you don't have to have money to register a project or a grant in that system.
Thank you.
Thanks, Dinesh. Okay, now to the fun part. Statistics. So today, all we're going to do is learn to speak the language of statistics. I'm going to reintroduce you to things that you have heard before. Hopefully you understood them before. If you didn't, I'm hoping that the understanding will come today. The first term, obviously, to define is the word statistics. So when we talk about the field of statistics, the things that statisticians actually do, what is that? Statistics is just a set of tools to help decision makers come to a conclusion when they cannot see the entire picture. So when we're faced with uncertainty, but we need to draw a conclusion or make a decision, statistics helps us do that. Some very common situations when there's uncertainty and a decision has to be made. Maybe we want to predict a patient's long-term chances of abstinence from smoking when their therapy would include both nicotine replacement and pharmaceutical therapy. It's a very common problem right now, right, is to get smokers to quit. We know the issues surrounding smoking, and getting smokers to stop long term is a very important problem. We also have another problem in our country with obesity. So if we want to estimate the prevalence of obesity in the United States, there's a lot of uncertainty in that. Why is there uncertainty? Because we cannot feasibly go and measure the weight and the height, or the BMI, of every individual in the United States. So we have to just get a small snapshot of what our country looks like in terms of obesity, and then make inferences or draw conclusions about the larger picture. We may want to estimate the survival of patients after some particular type of method, new method, gets implemented. So here we have transcatheter valve and valve implantation inside failed surgical valves. These are real objectives of 3 studies that were just published in JAMA in the last issue. So I have the reference here at the bottom. This is for the first one. Abstinence and prevalence abstinence rates for subjects in a study where they looked at combining pharmacotherapy with traditional therapies. So when we're describing this, we're talking about if we took a particular therapy and applied it to a population, what would happen to the population? And we can't do that in our research. We have to take it and apply it to a sample. So what we have here are statistics like the abstinence rates for one therapy, which is varenicline and the nicotine patch, versus varenicline and a placebo patch. 96 out of 216 subjects were abstinent between weeks 5 and 8, which was 44.4% of this sample, and 76 were abstinent out of 219 between weeks 5 and 8, which was 34.7% of this sample. So the quick picture here, just in this one section of the table, is that we have a difference of about 10% in terms of the abstinence rates at weeks 5 to 8. But what's really important here is the long-term quitting. So at 24 weeks, notice the rates in both groups have dropped from 44 to 33 and from 35 to 19. But we still see some benefit to having an active nicotine patch with varenicline versus not having a patch at all, or that placebo patch. So again, the uncertainty here is we want to know how this is going to work if we give it to everyone or if we make it available to a larger population. The second question had to do with obesity in the United States, and we already talked about where the uncertainty was for that. We can't measure everyone in the U.S., so we go and we collect a sample, and we see what that sample looks like in terms of our interesting characteristics, and then we make conclusions about what the population must look like from that sample. So this is just reporting the prevalence of high body mass index for adults aged 20 years or older. And they've broken it down by different categories because, as we all know, there are a lot of factors that are associated with obesity in this country. And then the third question had to do with survival of patients after a particular type of intervention was administered. Survival data is actually a really unique type of data that we'll talk about on the third day. Very often with survival data you see curves like this, which represent not only a time to an event, but whether or not an event occurred. So these curves can be thought of as survival curves, but what they're really representing is the percentage of subjects who have died in our study due to any cause by the study month and the type of valve failure. So you see here, stenosis was the type of failure. And what do we notice? That the rate of events is actually much higher early on for stenosis when compared to, for instance, regurgitation failure. And how do I know that? Because on the y-axis, higher values on the y-axis correspond to higher percentages of death. Here's another example by valve size. We see here that small valve label size has higher percentage of death across the whole study timeline. So the purpose of those examples was to show you that statistics is the tool that we need when we're making decisions when we can't see the whole picture. I would encourage you all to go and read this really quick, you can Google it, Plato's Allegory of the Cave, because that's what you're doing, right? In Plato's Allegory of the Cave, he's not really trying to demonstrate the usefulness of statistics. What he's doing is talking about education in general and how our own experiences reflect in how we observe nature. So statistics allows us to see a shadow on the wall and draw conclusions about the object that's making that shadow when we can't see the actual object. So you can think of the shadow as what's actually observable. Very often, it's not even just the sample versus the population. It's actually, for instance, progression of disease. So if you think about cancer, we really can't measure cancer progression, but what we can measure is tumor size. So tumor size is that shadow that's helping us measure the real outcome of interest, which is disease progression. All statistics does is provide you with the tools necessary to make a link or to predict or estimate what that object looks like from the shadow that you're actually observing. So this is the real picture, but I really like that Allegory of the Cave example. I encourage you to read it. It's a really interesting read. So statistics is a tool that scientists use to help model reality from a set of observations that they can actually see. So again, this is that object, this is reality that we never observe. We can never observe the entire United States population. So what do? We draw a sample, a particular type of sample from that population that's hopefully representative of what's actually going on. And then we summarize that sample, bless you, using numbers, summary statistics like the sample mean or the median or the standard deviation or a proportion. We also visualize that sample using graphs like histograms or box plots or pie charts. Utilizing these tools, we are able to make that link between what we observe and what the reality actually is. And we never really know how well we're doing, but statistics can help us quantify how certain we are in our results. Here's an example of one of the most obvious issues in research, which is confounding or lurking variables. Suppose you're concerned about the difficulties that some couples have in conceiving a child. So you're seeing a pattern here. This is that shadow on the wall, that you're seeing certain couples who have prolonged time to conception. And you're starting to see that in a lot of these couples, the female has actually been exposed to a particular toxin, whether through the workplace or another place. And you're seeing that the females who are either more highly exposed or exposed at all are the ones having greater difficulty becoming pregnant compared to those who are not exposed. So you decide that you're going to do a study to compare women who have been exposed to those who have not been exposed and record a measurement of this difficulty conceiving, which is the time it takes them to conceive. So there's a lot of problems here. There are a lot of things that could affect time to pregnancy. The individual woman has a lot of individual characteristics that could affect her time to pregnancy. Her spouse also has individual characteristics that could affect that time. Nevertheless, you're going to move forward and you're going to try to answer this question about the relationship between exposure and getting pregnant. Suppose that in your study, there's this other variable that you don't know about that could also reduce the chances of getting pregnant. We all know that women who smoke while they're pregnant affect their own fetus. So suppose women who smoke while they're pregnant actually reduce the chances that their own daughter that they're carrying will be able to conceive because the toxins in the cigarette affect the eggs in the female fetus. So if you didn't record this variable, you wouldn't know whether or not that was the variable causing the effect that you see, or if it was the actual variable of interest, which was this environmental toxin. So I have this nice little graphic here. This is the actual outcome of interest, which is fertility. There are lots of different things that can affect fertility. Genetics, other lifestyle behaviors. You hypothesize this environmental toxin is playing a role, but there are lots of what we call lurking variables that you actually are not even aware of in many cases that play a direct role in women's fertility. This is one possible outcome of this study. You sample women from your clinic, you determine their exposure to this toxin of interest, and then you measure their time to conceive. So what you see is an exposure status and then a time to conceive. And suppose in those that were exposed to the toxin, you actually observed a longer time to conceive. But the problem is there's this lurking variable, which is that exposure to smoke in the womb. And this is a made-up example, obviously. Let's suppose that the majority of the women who were unexposed to the toxin were also not exposed to smoke in the womb. So there's a match, right? Unexposed and unexposed. Likewise, suppose in those that were exposed to the toxin in the workplace that they were also exposed to smoke in the womb. So those that were exposed to one toxin were also exposed to the other. The question here is, was it the toxin exposure or the exposure to smoke in the womb that actually resulted in this prolonged time to conceive? And again, this is what's called a lurking or confounding variable. This will often result in what we call a type 1 error. Has anyone ever heard of the term a type 1 error? A type 1 error is basically saying there's an association, concluding an association, when in fact there's not. So why would a type 1 error occur here? I'm going to conclude that my workplace toxin is associated with a prolonged time to conceive, when in reality it's not. Why is that? Correct. Maybe it's the smoking in the womb, the smoke exposure in the womb that actually caused it. But because that is correlated with this exposure, it makes this exposure look like it's significantly associated. Unfortunately, with this kind of a design, which is what we call observational, this cannot answer the question that you actually pose because of this lurking variable. Now, if it wasn't this lurking variable, it could be a multitude of others that are not balanced across these two exposure groups. So this type of scenario is what we call bias. Has everyone heard the term bias? Bias just means that the variable that's lurking systematically distorts your results, meaning it's systematically making time to conceive longer in one group than it is in the other, making it look like the exposure to the toxin is actually what's causing or what's driving the prolonged time to conceive. So I'm going to get to this later when we talk about design of experiments, but this is the fundamental reason why in an observational study you don't show cause and effect. Because very often this thing is just laying underneath your research, causing this systematic distortion of your results. So you have to preface your discussion when you're publishing your study that this is an observational study. There are potentially many confounding variables that could have resulted in bias of our outcome. So we have not shown that the toxin exposure actually caused the prolonged time to conceive. There's another example of issues with lurking variables that's not bias. The second scenario, where we still have the unexposed and exposed toxin groups, now our smoking exposure is not necessarily correlated with the workplace toxin. This is very often the case. What it's doing here is it's causing noise in your data. So if you have a lurking variable, another exposure that you don't know about, that also causes changes in the time to conceive, but it's not the variable of interest, what it could be doing is increasing the noise in your outcome, increasing the variability in the time to conceive among those exposed to the toxin versus those unexposed, resulting in maybe you see a little bit of a change, but it's what we call insignificant. It's not clinically meaningful. And the reason that is because you have this other thing also associated with conception, time to conceive, that's just making your subjects very heterogeneous. So again, the question is, what does that result in? That results in what's called a type 2 error. Has everyone heard of a type 2 error? It's the opposite of the type 1 error. The type 2 error is concluding that there is no association when in fact there actually is. So in this scenario, let's suppose this workplace toxin actually is causing problems with fertility in women. But because your women are so heterogeneous with respect to other things, you can't detect that signal. So think of it as like the signal-to-noise ratio. The noise is so great in your data that you just can't find this real effect. So again, rather than bias in this scenario, we have what's called noise. So for those of you who are familiar with statistics, at least fundamentally, you know the term errors, or the MSE, the mean square error, or residuals, and how we always want to minimize errors in our data, either through statistical modeling or through making sure that our sample is very homogeneous, very similar with respect to all other characteristics except the factor of interest. And that's because we want to reduce noise and be able to detect interesting effects. I'm going to stop here and see if you have any questions or any thoughts. Nothing? Okay. Feel free to interrupt me at any time. So I think that I'm demonstrating here through these examples and some allegories, some very old allegories, what the role statistics plays in research in general. Any conclusion that you draw when you can't see the entire picture is going to come with uncertainty. So statistics quantifies that uncertainty. It kind of tells you, how good is my result? How confident am I in my result? So the things that help quantify uncertainty are things like p-values, significance levels, type 1 and type 2 errors, confidence levels, standard errors, confidence intervals, and then, of course, proper interpretation. So make sure that you don't try to say we've shown or we've proven when you really haven't proven. Maybe you're just giving initial looks into what could possibly be going on. This feeds into evidence-based medicine. So what is evidence-based medicine? Someone want to define it for me before they read the slide? Evidence is what? Let's be Sherlock Holmes for a moment. What is evidence? Observations, real observations, data, but observations taken in the context of what generated them, right? So very often, if you're familiar with Sherlock Holmes, which I love Sherlock Holmes, so I use a lot of his examples, he sees the broader picture and all the possible scenarios that could generate the observation. Whereas Watson, what does Watson do? He doesn't pay quite as much attention to detail, right? So it's elementary. But so you have to do evidence-based anything. Evidence-based practice means gathering evidence in the form of rigorous scientific data and understanding the context that generated that data, and then applying the scientific method to inform your practice, establish or develop new therapies, devices, programs, or policies aimed at improving health. And of course, this definition can be modified for evidence-based anything, because we're not all in medicine. Maybe some of you are more in public health or evidence-based statistics. We do that as well. I want to make note of a really interesting read. This is something that statisticians are guilty of. I think we're getting better at it, but I know that it's definitely something that researchers in general are guilty of, and it's living or dying by the p-value. This article is a fascinating read. It's free online. It's in Nature Methods, and it talks about how we've really placed the p-value on a pedestal, and we should probably think about removing it, or being better users, and statisticians should be better advocates for proper statistical methods and trying to demonstrate to the general public what a p-value actually is. So this entire set of lectures is going to revolve around hypothesis testing, which of course everyone knows generates these p-values. So I'll try to link back to the interpretation, the proper interpretation of the p-value, and its weaknesses. In general, what this article is saying is you cannot report a p-value unless you report an effect size. Because you can get anything to be statistically significant. You can get a p-value of 0.001 if you just keep observing, because the p-value is directly related to the size of your study. If you see a p-value of 0.01, you should immediately go and look at, well, what was the actual effect? If it was just tiny, then that could have been noise, but your study was what we call overpowered. And so you would be reporting a significant result with a p-value in a journal when, in fact, it was clinically just not meaningful. It was basically you're reporting an overpowered result. So I encourage you to read this. If you would like me to email you this specific citation, I can do that. But it's in Nature from February of this year. It's just called Statistical Errors by Regina Nuzzo. Very, very good read. And you don't have to be a statistician at all to read it. So the different types of evidence. So the scientific method said that we have to take scientific evidence in the form of data, actual observations. So what is scientific evidence? What is data? It's empirical, gathered in accordance to the scientific method, which serves to support or counter a scientific theory or hypothesis. There are different types of scientific evidence, and again, that's why I talked about you have to be careful about interpreting the data or the observation in the context that generated it. So a lot of data is just what we call descriptive or epidemiological, meaning it just occurs without any intervention. There's also other types of data that's intervention-based. So that you can think of this as like clinical trial data. Clinical trial data, a descriptive or epidemiological type of observation is like the example that I proposed with the workplace toxin. So you could kind of already see that the data there had some weaknesses. Intervention-based means that the investigator has a little bit of control over the experimental scenario, so maybe there's some randomization involved. And randomization, the whole purpose of randomization is to minimize bias, minimize lurking variables, so you automatically have increased the strength of your result when you do intervention-based methods. The problem with intervention-based methods is that you actually exert, sometimes, so much control over the situation that that scenario that you've created in the clinic to produce the result you saw will get watered down when you actually just push it out to the population, because the intervention itself won't be administered in the same way when it's out of your hands. Think about it this way. When they were evaluating the effect of Tylenol for pain management, I'm sure that they had some very specific parameters and dosing guidelines. But how many of us actually take Tylenol in the proper way? Or whenever you get antibiotics and you're supposed to take it every 4 hours. How many of us take it every 4 hours? Oh, I forgot. I'm going to take 2. So there's some changes between type 2 and type 3. And we would think that type 2 would be the best. But it's actually not, because we have to take into account how well is this thing going to work when I place it in reality. It may work really well when I exert full control over the situation and make sure it's administered properly. But in reality, that's never going to be the case. It will be for some individuals, but for the majority of people, we're going to not take things as directed perfectly. So it may reduce the effect or the efficacy or the safety of the intervention. But the benefit of evidence-based medicine, of course, when you rigorously test a method or a policy using evidence-based principles, when you place that policy out, when you implement that policy or you place that intervention out in the general population, you can bet that you have a high likelihood of successful outcomes because it's been tested. It's been tested in that population. The data has shown that it's effective and safe, for instance, that it's in some way better than what's already being used, and you get efficiency here. So very often evidence-based medicine will produce something that costs less but is just as effective. So you have the potential for more efficient use of healthcare resources. Any questions? No one's asleep yet, so I'm going to say this is a success so far. The scientific method. So we all learned this when we were first introduced to science back in elementary school. The scientific method is what we're using every day if we're researchers. It's actually what we're using every day if we're just human, because we always make decisions about when are we going to leave for work. You know, I check my Google Maps app on my phone to figure out what's the route I'm going to take today based on the traffic, because it has a traffic feature. And it will automatically calculate the fastest way, because I live in Olathe. I have to drop a kid off in Leawood, a kid off in Shawnee, and then I come to work. Yeah, so I spend a lot of time on the road. So I use the scientific method, the principles of the scientific method, to figure out my route to work every day. You observe, you revise, and you experiment. From the experiment, you get new observations, which then revise your hypothesis or your theory, and then you move forward in more experimentation. In clinical evaluation, this translates directly. Clinical evaluation starts somewhere, and it starts with observation, which is evidence. Maybe you start with case studies, like you see one patient who responded in such a unique way to some therapy that it made you think, wait a minute, why was this response so different or so good or so unique? So you create a hypothesis from that, either a testable hypothesis or one that you just move forward with in observing more patients. At some point, you've gathered enough observation or enough data that you decide, I'm going to have to run an experiment to test my hypothesis. So you set your experiment up to be able to test that hypothesis. That experiment generates data. That data either supports your hypothesis or it conflicts with it. So if it supports it, well, then maybe you refine your experiment, you make it bigger. You replicate that result to see if it was a real result or if it was just a chance result. So that's where the probability comes in. If your data or your evidence conflicts with that hypothesis or that theory that you have, then what do you have to do? You have to revise your theory and then move forward again through the scientific method. And this process never ends, ever. Sometimes you come up against a wall, but all you're doing at that wall is revising your hypothesis. The different types of studies that you use in the scientific method, you usually start at the bottom, unless someone's already started at the bottom for you, and you just Start with a case study, for instance. You're observing things as they happen in your clinic or as they happen in the population that you're researching. Then you focus on a specific interesting case. And then maybe that case becomes multiple cases, a case series. And you're starting to see a pattern develop, and then it turns into experimentation. I put this slide in here to show that not every study needs to be definitive. You have to start somewhere. There's a progression in learning, and we have to start at the bottom, figure out what's been done and what's the next logical step. So you may be just at the stage of exploring. In that case, you're probably doing a pilot study or a case study, and that has value. But the interpretation comes with ambiguity because you have a lack of control over the experimental situation. So you have lurking variables, or really too small of a sample size to say anything definitive. Once you've explored things, maybe you want to describe, estimate, classify, establish relationships. So X is associated with Y. And then finally, the ultimate goal of anything is to establish causality. If I do this, then this will occur. X causes Y. And again, the only way to really establish causality is to exert full control over the situation by doing a randomized controlled experiment. The different types of studies are along the bottom of this graph. This is the typical name of them. They may have different names depending on what field you're in, but I've classified them into what we call descriptive or observational studies versus analytic studies, where we're actually doing analysis. Here we're just describing populations or individuals. These are the most common individual studies, like a case report or a case series, cross-sectional studies. Analytic studies can be like a case control or a cohort study where we're actually comparing groups. Why are they observational? In this case, case controls and cohort studies, that factor of interest, like that exposure example, you don't randomize that. You don't exert control over that. You don't manipulate it. It comes already in place. Either they self-select to smoke, or they self-select not to take DHA when they're pregnant, or they self-select obesity, that kind of thing. Experimental means that factor of interest, your X, you actually exert control over it and you randomize it. So I'm going to randomize subjects to either the standard of care or to my new experimental therapy that I think will work just as well, if not better.
So a survey-based study where you're handing out a survey and the questions will be focused?
It depends. It could be. It will definitely be observational. It could be a cohort study. We'll define these more explicitly, but survey methods are not randomized. If you're just asking a specific question, if you want to elaborate a little bit more on what you're.
Just going to present it to certain populations with a series of maybe 10 questions. To get some data as to why they chose one versus the other in their own choices.
Oh, so you're asking what their choice was. I would say that that's not even a cohort study. You're really just trying to figure out why they self-selected into a particular group, right? Yeah. I'm going to. Oh, that kind of classify them. Actually, then it could be a cohort study if you're doing it that way. Yeah. And I'll explicitly define each of these in just a few moments. So observation versus experiment is pretty straightforward. I've already talked about it. Observational study includes conditions that are observed, not assigned. An example of an observational study could be that valve replacement example that I had in one of the first couple of slides, where investigators didn't actually go in and randomly assign individuals to particular types of procedures. They just had a data set, a very large data set, that recorded which procedure was used and what the outcome was. So that's more observational because they were observed. A designed experiment, in a designed experiment, you actually assign the conditions, the experimental conditions to the subjects, and preferably in a randomized fashion. And we'll demonstrate randomization and the benefit of it in a moment. Here's an example of a heart study. The question is serum total cholesterol and how it's associated with age, gender, and education, and in particular, blood pressure medications. And then, if the subject smokes, does that affect any of these relationships? So you have 3,000 subjects over 2 years. You take blood samples and have subjects answer a cardiovascular disease risk factor survey. The outcome of interest is their serum total cholesterol. All of these other factors we're observing. So this is an observational study. The primary factor of interest, our independent variable, if you will, is blood pressure meds, which are observed, not assigned. What could be some possible confounders here? The way you can think about a confounding variable or a lurking variable is it has to be a factor or a variable that is associated with your outcome. So think of all the things that are associated with serum total cholesterol that we're not measuring. Diet. What else? Exercise. What else? Genetics. Yeah, I mean, and on and on and on. So that's how you identify things that you should probably be measuring, or use those variables to limit your population that you're actually going to look at to make sure they're homogeneous. So what's one way to use age? Well, let's not even do that. What's one way to use, someone said exercise, right? How could we use the confounding or lurking variable of exercise to limit the people that we sample or recruit, to make sure they're homogeneous? Sedentary, that's what I was looking for. So for sedentary people, what am I doing? I am controlling for this confounder, which is activity level or exercise, by limiting what I'm looking at for this study. What's the problem with doing that? Yeah, the generalizability.
But then you could do it over 3 different groups.
Correct. Or we could record, if we're doing 3,000 subjects, what could we also do? We could just record it, right? So we could either use it to limit the sample or limit the population we're looking at, but that affects the generalizability, or we could just record it if we have a big enough study. The problem is very often we're not doing a study with 3,000 people. We're doing it in 30. So maybe you're going to get 75% sedentary and 10% that do, that exercise once a week, and then a handful that, exercise every day. So there's lots of different ways to account for confounders in observational studies, but the key here is knowing what the confounding variables are. There are other confounders that we're not aware of, that you cannot possibly adjust for everything out there that could be causing serum total cholesterol to vary in a human being. But I could use a randomized controlled study where the randomization theoretically balances the confounders between my different groups and sort of eliminates their effect from the study. Here's another example in diabetes. The research question, will a new treatment help overweight people with diabetes lose weight? We have 40 obese subjects with type 2 diabetes, 20 are female, 20 are male. This is a randomized, double-blind, placebo-controlled study of treatment versus placebo. The outcome of interest is weight loss, and the factor is their treatment versus placebo. So there's a couple things that we could talk about here. This is obviously not an observational study, it's an experiment, because I am exerting control over the experimental condition. They're either going to be randomized to treatment or randomized to a placebo. Randomization should help balance lurking variables across groups. But the problem in this study is that we only have 40 subjects. Randomization works really, really well in large studies, and it tends to break down in small ones. So what have these investigators done with known lurking variables? Think about, again, what is a confounder or a lurking variable? It's another variable that you really don't care about that could affect your outcome or that's associated with your outcome, weight loss. So two things that I see here. Anybody want to, what confounding variable have they already kind of taken care of through the design of their study? Yeah, so gender does have an impact on weight loss. Men have a higher percent muscle mass. They tend to lose weight more rapidly, at least early on. If you looked at long-term weight loss, it may be more comparable, but short-term weight loss, men are probably going to win out. So they have made sure that they have a balanced sample of 20 female and 20 male to kind of take care of or make sure that they don't get, for instance, predominantly males or predominantly females in their study. They also classify only obese adults. Why would we be interested in looking at a weight loss therapy in just obese people versus maybe allowing people to be slightly overweight, moderately overweight, obese, in particular in a sample size of 40? Correct. They need to start at the same baseline because there is a lurking variable here. Starting weight. Individuals who weigh more can potentially lose more, right? Even a higher percent of their body fat can be, depending on how you're actually measuring weight loss. That's a lurking variable. So they are limiting their sample to just obese adults because what it does is it makes sure that I'm looking at sort of one end of the spectrum and I don't get the whole range in a small study and then end up accidentally or by chance getting all of my larger subjects in the placebo group, making the treatment look not as effective, right? Because all of those larger subjects, even on placebo, could potentially lose more weight with no intervention than subjects on the treatment group if the subjects in the treatment group are, in general, smaller with less weight to lose. So is this becoming kind of clear how you could control for or how you need to start thinking about all of the things associated with your outcome and how you could either account for them in the analysis or account for them in the design? When should you seek a statistician's help? I would say as soon as you want to start thinking about your study. We have statisticians in our department who have done so many research studies in a particular disease area or application area that when investigators come to them, the statisticians actually change their aims because they realize this is not a feasible aim or it's not even really what you're trying to do. What you're really trying to do is this. It's not because the investigator's not brilliant. You guys are the scientists, but statisticians think a little bit differently about, we're trained, right? We're trained to design studies. We're trained to help interpret results. We're trained to do analyses. We're trained to know how data needs to be structured or collected. That's our strength. And it doesn't have to be your strength. That's why collaborative or multidisciplinary teams tend to produce the best results. So, when should you seek a statistician's help? When you need help interpreting the literature, this is kind of, you need to do this first before you can even define your research question or your aims. So if you don't understand why someone did a particular thing in their published study or why that p-value resulted in this particular conclusion, or they have these particular limitations, come see a statistician and they can help you work through that. So we can help you define research questions that are testable and feasible, the data collection instruments. We won't, for most studies, tell you you have to use this expensive software. You can use Excel, but we're going to give you parameters for how you actually set up your database, how you enter in your data, just to make sure that the data has quality and that it's not going to cost hundreds of man-hours to clean it at the end. And I've gone through that before because of getting an Excel spreadsheet where the investigator just didn't understand or know to think about certain ways of entering in the data. And then, of course, determining the appropriate study size. If you don't determine your appropriate study size, then you could get a result that doesn't, I mean, it was a waste of time to do the study. Maybe you didn't have enough subjects to even see anything, or you had so many subjects that you wasted someone's money, and that's a bad thing as well. The key, though, is when you come to a statistician, what do you need to bring with you? What does the statistician need to know to be able to help you? We're trying in our department to make individual faculty members learn about an area. So if you do cancer a couple of times, or if that's the thing that you tend to do most, we're going to focus you in cancer. That way you learn the terminology. You learn, because we have to learn your language as well as you learning ours. So that's the most optimal thing, is getting a statistician who works in your area, if not all the time, say the majority of the time. So what do we need to know whenever you come to us? We need to know, number one, the general idea of the research. It would be nice if you already had your specific aims and hypotheses laid out. What is the objective? What is the specific aim? And what is the hypothesis that will meet that objective or test that research question? We also need to know what's been done before. So whenever you're writing, for those of you who write grants, you have to kind of justify why you're doing what you're doing through a literature review. Show where the hole is in the field and how you're going to fill it with your particular project. So a nice literature review of that supports the general idea of your research and your aims would be nice. What are the outcomes under consideration? And be specific. We're going to talk about specifics here in a moment regarding the types of outcomes under consideration. So when I say the type, I don't mean we're going to measure this syndrome that has like fuzzy definitions. I want to know, this is the measurement, this is how it's collected, this is what it's actually reflecting, this is the type of number that will be generated, this is what the number is interpreted as, what are the other possible alternatives to this outcome, and why did you choose this one? I need to know as a statistician what the outcome is, because that will tell me what method's appropriate. How am I going to power this? Those kinds of things. The study population, so you're looking at individuals that are maybe just obese, and you're looking at a weight loss intervention. And then what is your actual experimental factor, if you have one? This is assuming that you have a designed experiment. Are you looking at a drug? And if so, what should you be comparing it to? Or can you compare it to something? An intervention, a device. The rationale for the study, and then, of course, budget constraints, because, I mean, we have a salary too, and we have to cover it. So we need to know whether or not you have any money to work with. If you don't have any money or you have limited funds, we still try to do as much as possible, given the resources that you have, to make sure that you have a successful study. This is just another quote that I like. I think that this really lays out the foundation of hypothesis testing. No amount of experimentation can ever prove me right, but a single experiment, actually a single observation, can prove me wrong. I like to use, I'm actually going to use this disproving the null. The swan example. Has everyone heard of the book The Black Swan? Yeah, so that's really what hypothesis testing is doing. Suppose I walk in and I claim, I've been all over the world. I've visited 70 countries, and I've only seen white swans. I've seen thousands and thousands of swans, and they've all been white. So I'm going to say my theory is that all swans everywhere ever imagined must be white, because I've never seen anything else. I can keep traveling and keep traveling and keep observing and see nothing but white swans, but I'm never proving myself true. How could I prove that this assertion is true? Number one, it's really not feasible. But let's say if I could observe every swan in creation and see that they're all white, then I could prove that's true, right? But then in that case, what's the point of research? Because there's no uncertainty in that, right? I can see 100% of the population. I can see that they're all white. There's no uncertainty there. But in general, when we do research, there's uncertainty. There is a small fraction, or sometimes a very large fraction of the population or of the picture that's not observable. Contradictory evidence, though, is what can prove or disprove a claim. So how would I very easily disprove that all swans are white? I could just happen upon the black swan. And that's what that book is about. So again, more reading, more food for thought, to get you thinking like a researcher and about science. There's a book called The Black Swan. I highly encourage you to pick it up. You can get it at the library for free and read it. It talks about those observations that are just so not probable or plausible, but still occur. And that's the black swan that can throw your entire theory out the window. Totally change course of science or of research. So contradictory evidence in the form of a single black swan makes it clear that the claim is invalid. So I just have to run across one to refute my thousands and thousands and thousands of miles of travel to find all the white swans in the world. And so again, that lays the foundation for hypothesis testing. Your claim, the claim that you're usually interested in, is what we call the alternative hypothesis. This is the one thing that I hate about statistics, is the terminology that we associate with things is almost the opposite of what you would think it should be. So it doesn't really translate into English just as well as it should. When we say something is an alternative, we think that it's something that's not really of interest directly to us. It's the other thing. But it turns out this other thing is what we're usually interested in. So if you're interested in showing that there's an association between your intervention and increased weight loss, that's actually your alternative hypothesis. This is the statement of differences or association between variables. That's usually what we're after. There are some small cases where the opposite is true, but in general, the alternative hypothesis is what we're after. This is what we want to prove. We want to prove statement X. But what did I just say? We could never prove an assertion through confirmatory evidence. But we can very easily disprove something, right? So in a roundabout fashion, if I want to prove all the Skittles in my jar are blue, all I have to do is pull a green one out, right? And what I really wanted to show was that they're not all blue, but in order to support that hypothesis, I have to actually disprove all other possibilities. So hypothesis testing is a very unfortunate, philosophical, convoluted kind of thing. But I think if you get the general gist, get away from the notation and get away from the process and think about the big picture, you'll start to see that it's an ingenious method for supporting a theory. What you do is you take your theory, you make it an alternative hypothesis, and then you move forward with science and attempt to disprove all other possible scenarios. So if you disprove everything else, then what must be true? The thing that you think is true. You didn't directly support it, but you contradicted every other possibility. Did you have a question?
So you basically prove your hypothesis by not disproving your hypothesis.
You actually, I wouldn't say prove, you support your hypothesis by disproving every other possibility. Does that make sense? So it's what you said. I mean, we can argue a little bit over the language, but yes, you're essentially proving it by disproving other things. And that is, of course, why this other hypothesis is called the null hypothesis. Can someone tell me if that clock is correct? I can't find my phone. 9:40? Okay, just making sure, because in past years it's not been correct. So again, this hypothesis testing procedure is a very common procedure that we use in the scientific method when we do experimentation. You can think of it as when you come to a fork in the road, it tells you which road to take. Once you take a road, you'll come to another fork. Which of those roads do I take? So hopefully it's guiding you through all the different possibilities as you're doing research. Observation creates a hypothesis, which produces an experiment, which produces data, which then either supports a hypothesis or conflicts with it. If it conflicts with it, then we revise, we reject, we revise, we do further experimentation, and we just keep going through this loop. We keep changing course, or at some point, our evidence supports the hypothesis of interest. The way that this works statistically, you're going to get things like p-values, you're going to get things like confidence intervals, but what's really going on here is when we hypothesize about what something looks like, what we're really saying is what we expect the sample to look like when we draw from the population. So if I hypothesize that the mean response of a population is 26.3, what I'm saying is if I take a sample of observations of data from that population, they should all be very similar to 26.3. In fact, maybe their average of that sample is very close to 26.3. That's my hypothesis. But then I actually go out and collect data. In my data, I record the observation from the sample, and I observe a sample mean of 26. So I have two different things here, right? I have a hypothesis, and I have evidence. Does the evidence support the hypothesis, or does it conflict with it? (26.3) versus 26. Does that look like it's kind of close to 26.3? Yes, right? Yes. I've given you this picture just to kind of show you. Has everyone seen this curve before? It's called a bell curve or a normal distribution. Along the x-axis are all the possible values my outcome could take. So I'm saying from 24.5 to 28. It actually goes out to negative infinity and positive infinity, but we don't draw it out that far. Along the y-axis, you get the chances or the likelihood of that particular observation occurring. So at values of x where we have a curve that's very high, those are very likely values, right? At values of x where the curve is very low, those are very unlikely values. So if I hypothesize 26.3 and I get a value of 26, visually we can see that this is actually very likely to occur if that hypothesis is true. What if I get 27.5 from my sample? What does that say? I have evidence in the form of actual empirical data, and then I have a hypothesis, a theory, that's not observable. It's just my opinion based on observation. Do they conflict, or does the data support my hypothesis? Look at the graph. What are the chances of that value occurring in a sample? Don't be afraid to speak up. Is it low or is it high? Low, right, it's low. So, what does that tell me? That tells me if I hypothesize that my population tends to produce values that are around 26.3, but in actuality, the data produced a value of 27.5, with this setup, my data, my evidence is conflicting with my theory. So what are you going to believe? Something that's observed, empirical, or something that is hypothesized? The observation. Correct. In the context of the situation that generated the data, right? So again, everything is within context. If this value came from an observational study, I would not weight its strength as highly as I would from a randomized controlled trial, right? Because of all the issues we've already talked about. So again, in general, we follow the data, follow the data, follow the data. But be wary of what generated the data. Make sure you can only interpret the observation in the context that generated it. So this is just a little bit more emphatic example. If I got a value way out there, in fact, it's so far out that it's off the graph, that's even more in conflict, right? We'll talk about values like 27.5, which are still, they still look improbable, but, you know, where's the cutoff point? Where do we place that magical cutoff point? We'll talk about that in a moment. Values like 30, it's pretty obvious that they're not going to happen if our hypothesis is true, but there is some uncertainty when we're right here. So we'll talk about that in the context of things like confidence intervals and p-values in just a moment. So again, to reiterate, if the observed data seems odd or unlikely under your hypothesis, then in the context of hypothesis testing, what do? We reject the hypothesis in favor of the alternative. So the question that you asked a moment ago about the general structure of hypothesis testing, how it seems kind of backwards that if we want to show something is true or support something, we actually test something else. This is why, because we really are after the alternative, that there is an association or that there is a difference. So we test the opposite and we gather data that conflicts with the opposite in order to sort of indirectly prove our alternative hypothesis. And typically, the p-value is used as the measure of strength of evidence against the null hypothesis. Now, the terminology here is in English, and we could argue over a little bit about the semantics, but again, I want you to go and pick up that statistical errors paper and take a look, because the p-value is not the end. There's more work to be done once you get that p-value. Before I talk about what a p-value is, I'd like to stop and see if there are any questions. We've had some great ones so far. Does everyone kind of see the purpose and the conceptual process of how hypothesis testing is in the scientific method and how it's at a high level working? Because we're about to get into some of the details, and I don't want you guys to lose the big picture. No? Okay. So what is a p-value? Would someone like to give me a definition? No? The p-value is a probability. The big question is, probability of what? And very often it's misinterpreted. Unfortunately, it's beyond the scope of this lecture series to really talk about what this distribution is really representing. But we can think of it as the example that I had before. It tells us how likely I am to get a sample with a particular characteristic. So if I'm interested in a mean, I gather my sample from a population where I've hypothesized that the population mean is 26.3. Now, a mean, a sample mean, is a statistic, so it's going to vary depending on the individuals that you actually sample. So the value of the mean could be anywhere from some small number, which is off the graph here, but very likely it's above 25, and very likely it's below 27.5. But I could theoretically get any value between those. If my hypothesis is true, my null hypothesis, then I'm most likely to get values that are right around 26.3. So that's represented by the fact that this curve is at its highest values for values pretty close to 26.3. But again, I'm going to grab a sample, hopefully in an appropriate way. I'm going to observe the mean of that sample, and I'm going to see, using this distribution, which has mathematics behind it, how much it either conflicts with this hypothesis or supports it. And that quantity that we usually get is called the p-value. So let's suppose in this case I get a sample mean of 27.25. I know it's kind of hard to read the x-axis here. So my question at that point is, well, how do I know if this conflicts with my hypothesis? And if it does it conflict enough that I'm comfortable saying my hypothesis is not true? And that's where the p-value comes in. So the p-value, for those of you who have had your basic undergraduate stats course, everyone remembers it's the area of the tail of the distribution past what you actually observed. So it's this, if you've had calculus, you integrate and you find the area under the curve past where you actually observed. In truth, it's the area under the curve for values of the mean that are more extreme than what you observed in the sample that was actually gathered. So that's the true definition of it. And what do we mean by more extreme? We mean more in conflict with our hypothesis. So it's further away from 26.3 than what we actually observed. Yes, you want, because in general, right, we're trying to disprove that this distribution actually looks like that. If you remember again from your basic stats course, so there were some times when it was on the left, sometimes when it was on the right, sometimes when it was on both. That is determined by your actual research question of interest. What am I actually trying to support? And that's the alternative hypothesis. So if you state in your research hypothesis that the mean is greater than 26.3, then the evidence in support of that is going to be on the right-hand side of this distribution. So that's where your p-value is calculated. If you state in your research hypothesis that it's less than 26.3, then the p-value is actually to the left of the observed mean. If you don't give a direction, you just state that it's different from 26.3, well, where does that occur? That occurs at large values and at small values. So that's when you had the two tails. In English, I'll let you all read this. The p-value is the probability of getting a sample, some evidence that is as favorable or more favorable to your actual research hypothesis than what you actually observed, given the null hypothesis is what's generating your sample. I don't see any quizzical looks. Does that make sense? Again, this picture is that hypothesis, that theory that we're trying to disprove. Hopefully, the evidence will occur in one of the tails. And then we use the p-value to quantify how strongly our data supports our hypothesis of interest rather than this theory that we're trying to nullify, the null hypothesis. And I made a little bit of a reference to one-tailed versus two-tailed in terms of our hypotheses. So just vocabulary purposes, a one-tailed hypothesis is used when you hypothesize that a particular directional relationship is going to occur. So for instance, when I administer this experimental drug, I expect a decrease in systolic blood pressure. A two-tailed hypothesis would be when the direction of the effect is unknown, or you want to be very conservative and actually capture evidence for either an increase or a decrease. So in this case, we could say the experimental therapy will result in a different response rate than that of the current standard of care. I'm interested in seeing whether or not it will either increase this response or decrease this response. We've already talked about errors in the context of the workplace toxin example. Remember when we had that lurking variable and it either produced bias or noise and caused us to make an error in our decision about the relationship between the toxin and the time to conceive. This is just a formal definition of those types of errors that you can make when you make a decision at the end of a test. The type 1 error, which you guys will most be familiar notationally as alpha, it's when that null hypothesis, again, the null hypothesis that we're trying to disprove, we're trying to nullify, is actually incorrectly rejected. So what you say here is that I think there's an association, or I'm going to conclude there's an association between the workplace toxin and a prolonged time to conceive, when in fact there's not. And that's an error, and that's a type 1 error, alpha. We pretty much give emphasis to this because this is what we compare our p-value to, and everyone loves p-values. So the commonly accepted rate for alpha is 0.05. When you get that p-value from your test, generally this is that cutoff point at which you say that this result is statistically significant. And again, I referenced the paper about the limitations of statistical significance. If you wanted to think about this error, though, in the court of law where these things were, this magical cutoff point of 0.05 was sort of birthed, an innocent man being proven guilty in a court of law is thought of as a type 1 error. And we call it type 1 because it sounds like it's the worst possible error that we can make. It's the worst. Putting an innocent man in jail is a very bad thing, right? We never want to do that. Type 2 errors, which is beta, and again we call it type 2 because in most cases people think that this is the lesser of the two errors. We allow this one to be a little bit more frequent. We fail to reject a false null hypothesis. So what does that mean? In the context of the court of law, you have a guilty man, and it's determined that he's not guilty in a court of law, so he's set free. Notice that we often allow this to be as big as 20%. Now I'm going to take a step back here, though, and I want to talk about this in the context of clinical studies. And this is another issue, again, with the p-value, that we just tend to emphasize things because other people emphasize them. Let's look at this in the context of the court of law example because sometimes it's easier to put these things in those scenarios. Let's suppose that this man, who's either innocent or guilty, is being tried for capital murder. What are the consequences of proving or showing or determining that he's guilty of capital murder when in fact he's innocent? Death. It's a pretty severe consequence, right? If we make that kind of error, I would say I'd want alpha to be smaller than 0.05. I don't want to make that 5% of the time. I want to make it 0. If the guilty man, the man that is guilty of committing capital murder, is actually not guilty, he's determined not guilty and he's let go, that's also an error. It's bad because he could murder again, right? But is it as bad as the error that we made in putting an innocent man into prison and possibly putting him to death for a crime he didn't commit? Which of those is worse? The first one, right? I would rather sort of err on the side of caution and let the guy go, as opposed to putting an innocent man to death. Now let's suppose that what he's being tried for is a traffic ticket. And reread that. What is the consequence of proving a man that's actually innocent of jaywalking is guilty? What is he going to have to do? He's going to have to pay a fine. Yeah, he'll be mad and maybe he'll be late on a bill, but big deal, right? What about if the man is actually guilty and he's proven not guilty? Yeah, exactly, right? More money, he can go out and do whatever he wants. So my point is, sometimes we tend to overemphasize the wrong thing. Alpha is not always the most important error. Alpha should not always be 0.05. Alpha sometimes can be as high as 0.1, maybe even higher, some people can argue, meaning that p-value that you get from your test that you compare to alpha, 0.05 should not be like the 13th commandment. It's really just a guideline for well and properly designed experiments, again, in the context of what they're trying to do. If you're doing pilot work where you're really trying to just see trends, but you don't find an alpha p-value of 0.05, your p-value is 0.09 or 0.07, I would argue that that's statistically significant in the context of your situation. There are times when the type 2 error is the more important error and should be smaller. So if you do clinical research, the type 2 error needs to be emphasized towards the end of clinical research. Why do we want to do that? Think about what we're doing. Power. We want to really see it, right? We want to show with high certainty that this effect is there or not. So I think I've made my point. I don't want to spend too much more time on this because it's already 10 o'clock. Power, typically when we talk about studies, we talk about them in the context of the type 1 error and the power. Power, notice, is just 1 minus the probability of a type 2 error. And these are the two features that we generally want to talk about. Yes? Uh-huh.
In your earlier example of that workplace toxin,
Uh-huh.
you pointed out that there wasn't an observable problem.
Uh-huh.
And then you had evidence that backed up that there was a problem.
Uh-huh.
It wasn't exactly what you were looking for.
Correct.
For your example there,
You're having a hard time linking it back to that example?
that example, would it be more of a guilty man proven guilty, just not by the means the evidence shows?
Well, you have to think about what your actual question here really was, right? You didn't know about this lurking variable, which is exposure to smoke in the womb. And you really don't care about exposure to smoke in the womb. What you care about is the toxin. And in this situation, the toxin is actually not affecting time to conceive. Let's suppose that's the reality. Oh, okay. Yeah, no. Yeah, this is the association. So what you're doing here is you're erroneously linking this toxin to prolonged time to conceive, when in fact the toxin is meaningless. It's the lurking variable which results in bias. It systematically distorts the time to conceive, making it look like it's the toxin doing that. So that's just one of the problems with a lurking variable, is that you could make a type 1 error. Does that help?
Yeah.
Perfect. So let's move forward. We talked about the p-value. We had some vocabulary. This is the nice little decision kind of graph that most people see. We never know the truth, so we never know if we make these errors. All we can do is design our study to minimize the chances of those errors occurring. So this is just a nice little graphic to show which one of those falls into which decision when the truth is either the null, which you're usually trying to disprove, versus the alternative. Lots of things that can influence how powerful your study is, or your predisposure to making errors. So the things that influence the power of your study are the effect size. And we talked about that briefly when we were talking about this paper on statistical errors and the p-value. The effect size is the magnitude of the difference, the magnitude of the association that you wish to find. As that gets bigger, you can think that the signal that you're trying to detect is actually pretty large, so you should be able to find it more easily with fewer resources. So obviously, as your effect size increases, your power will increase as well for a given set of resources. If your effect size is really small, you may need a lot of data to find it. The variability of your outcome measure. So this is that issue of noise. If you choose an outcome that's really noisy, then it may make it more difficult to find an association or an effect. And the most obvious one that we tend to think about most is the sample size. So things become easier to detect the more you observe. That's essentially what it means. As your sample size increases, your power will increase. Other things can affect your power, though, when you're doing research in general, but in particular research in humans. Dropouts. So if you're doing something that requires subjects to return for follow-up visits in order for you to record things, dropouts can be a problem because it effectively reduces your sample size. Nuisance variation, this is just that second example, not the bias example, but the noise example that I had in the toxin example. So if you have another lurking variable that's just making your subjects much more heterogeneous or dissimilar, then it could inflate the noise in your data and allow you to be able to miss meaningful signals. Confounding variables, doing multiple hypotheses or post hoc hypotheses. If you stick to the rigors of statistics, this can actually increase the resources that you are required to use to find a particular effect. We will cover these concepts specifically and more in depth in the context of hypothesis testing and quality of evidence in a future lecture, but I want to move on because we still have to talk about descriptive statistics and how do we identify the type of outcome we have. That's really the first place to go when you're talking about how to summarize your data with numbers and with pictures. So statistics, really, the field of statistics falls into three different sort of categories. We either are trying to describe something, we're trying to design an experiment to assess something, or we're actually doing the analysis, the inferences using statistical methods. Today, I'm only going to talk about descriptive statistics. Next time I'll talk about design of experiments and a little bit about inferential statistics, and then the last two lectures will focus only on inferential statistics. Briefly, descriptive statistics is just describing the sample, describing the data, using numbers and pictures. Inferential statistics that's hypothesis testing, for instance, or confidence intervals, interval estimates, and things like that. You're trying to use the sample data to draw conclusions about a population. And then, of course, experimental design is just how do I arrange my experiment to actually test or generate data that would allow me to perform a valid test of my hypothesis. Before we can do any of the descriptive statistics, I need to go over the type of data. And again, I want to mention that the two most common questions I get as a statistician from researchers are, number one, how many subjects do I need? And number two, what kind of test do I do? So again, I'm emphasizing you're not going to be a statistician when you walk out of here, but you will be able to sort of understand how you go through that flow of determining what test is appropriate for your particular type of data. There is a concept that's been around for many, 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 many decades called level of measurement. And we're not even taught this anymore because it's so inherent in what we do, we actually forget that it's even there. But all data contains information, and not all data is created equal. Some data, some numbers actually contain more information about something, about an outcome, than other types of data. So it's important to recognize where your outcome falls on this hierarchy, which we'll call level of measurement, because it has an impact on how you describe the data and how you analyze it. So today, again, we're only going to emphasize part 1. We'll do part 2 in the remaining 3 lectures. If you look this up, the levels of measurement are classified into 4 different hierarchy categories here, where if we go down, we're actually getting increasing information. Nominal types of data have the least amount of information. All they indicate are subject A is different from subject B. A good example of a nominal variable would be what? There you go, gender, perfect. Perfect example. An ordinal variable, similar to a nominal variable, still is implying that A and B are different, but in its number, an inherent order is applied or implied. So if I say I am a freshman in college and my friend here is a senior in college, that is a classification. There is a difference between us and an inherent order implied in that classification variable. An interval variable implies, again, notice the increasing information, still the difference, still the order, but now we have this feature called equivalence of intervals. Whenever I gave you the example of me being a freshman and her being a, what did I say, a senior? Maybe I am 1 credit shy of being a sophomore and she's just into her senior year. That interval difference between the two of us, which is really represented by a different number, is not consistent for every comparison of freshman versus senior, is it? Because some could be literally just starting college and have no credits. They're a freshman, and they're different than me. So the equivalence of intervals means that the interval difference between the number 1 and the number 2, that meaning is the same regardless of where it occurs on the number line. Ratio takes that one step forward and provides this nice feature called an absolute zero. So everyone's heard of absolute zero whenever we talk about the Kelvin scale of temperatures. Absolute zero means that the zero has meaning. Zero means a total lack of whatever it is you're measuring. There are lots of situations where zero actually doesn't mean a lack of whatever it is you're measuring. If you think about temperature scales, what does 0 degrees Celsius mean? It has a meaning. It's a meaningful point, but what is it? Freezing temperature of water, right? So whoever Celsius was, I don't know the history of the scale, he or she decided, I'm going to put 0 of my scale at the freezing temperature of water and 100 at the boiling temperature, and then I'm going to scale everything in between. So that's not an absolute zero. What's 0 Kelvin? Anyone know the scientific definition of that? It's literally called absolute zero because it's a total lack of energy, total lack of energy, total lack of kinetic energy, total lack of temperature. So that 0 means something. We often hear these variables talked about more in these terms: discrete, continuous, qualitative, quantitative. But we can get even more specific. Very often we don't even have to get this specific. We can go here. But we have to make sure that we recognize the actual level of measurement, in particular for interpretation purposes. So again, to emphasize, ratio variables contain all the characteristics of interval variables in addition to more information. So this is just the hierarchy, where nominal really is the least amount of information you can get from a variable. I started here. These are sort of specific slides. Most information from ratio. Different values imply differences in outcomes. Order is implied. Intervals are equivalent, and 0 indicates a lack of what is being measured. So the interval equivalence becomes much more clear, I think, when you look at examples. If I have an outcome that is ratio, the difference between an outcome of 6 and an outcome of 7 is 1, right? If I subtract, that 1 has meaning, and it means the same whether that difference occurs between 6 and 7 or if it occurs between 101 and 102. Some examples. Age. 0 age means 0 age, right? Birth weight. Follow-up time to complete a task. Duration of survival. The dosage administered. Exposure to something. So 0 in these cases all has meaning, and the intervals are all equivalent, regardless of where they occur on the scale. One step down, we have that interval data, where we have difference, order, and equivalence, but 0 no longer applies absence of the outcomes. We already talked about the different temperature scales. For the most part, you can think of interval and ratio data as the same thing. You just have to be careful about when you talk about twice as much. So I can say that someone took twice as long to complete a task, but I can't say that 60 degrees Fahrenheit is twice as hot as 30 degrees Fahrenheit. That kind of statement doesn't make sense if the 0 doesn't have meaning. So again, the methods will probably be the same, the descriptions will be the same, but you can't make statements like this unless that 0 has meaning. One step down, we have ordinal data, where we have difference and order. Now, though, that we lose that characteristic of interval equivalence. I like to use sports examples. So we have a really good basketball team with this university. I'm sure everyone's heard of it. If you're Missouri fans, I'm sorry. The differences in performances in our leagues, for instance, let's say that KU is the second-ranked team in basketball. We'll say that. And let's say the first-ranked team is Texas. But really, for the most part, someone has to be 1, someone has to be 2, but maybe they're just equivalent, right? This is very often how it occurs in our league. We have premium, like great, great teams, and then there's everybody else. So they kind of run in packs. There's the top of the pack, and then there's everybody else. So the difference between the second-ranked team, which is KU by definition, and the third-ranked team, which maybe is Oklahoma State, which they're pretty good, but let's say it's Oklahoma State, that may be a larger gap. So the interval between 1 and 2 is very small. The interval between 2 and 3 is much bigger. It's different. So we can no longer interpret these intervals with any kind of meaning. We can only interpret the numbers in terms of their relative ordering. Some examples of ordinal data. I've already used the highest level of education achieved, right? In terms of freshman, sophomore, junior, senior. Stage and grade of disease. So a good example of that would be like, another example is tumor response. So we often classify response to cancer therapy in terms of a complete response or a partial response, stable disease, or treatment failure. The interval between complete and partial doesn't make sense. It doesn't make sense to even think about an interval. You're either classified into one of these categories, and one category is inherently better than the other, or worse. And the nominal data is the most easy to interpret because it just implies difference. We've already talked about sex being 1. ID numbers. One of the important things to understand is that all data, whether it's quantitative or qualitative, can actually come to you in a number. And just because it's a number doesn't mean it's continuous or quantitative. Gender, very often whenever you see it in a database, it's a 0 and a 1, where 0 represents female, 1 represents male. That's why we have to be careful about what we do with the data. You would never want to report the mean gender. Even though you got a 0 and a 1, the mean gender could be a 0.7. But what does that even mean? So, again, the importance of understanding what your numbers actually mean. ID numbers. they are a number, but they really only distinguish between individual subjects. And then like a pass-fail response. So they either responded or they didn't to therapy. So again, why am I wasting 10 minutes on this? Because it tells us if we can identify the type of outcome we have, very easily we can figure out how we're going to describe it appropriately. And then we'll see later how it helps us determine how to analyze it. The levels are in increasing order of mathematical structure. So the more information that the number contains, the higher it falls on that scale, the more you can actually do with it. You can actually report a sample mean on an outcome that's interval or ratio, but the sample mean, a mathematical formula, doesn't make sense on ordinal or nominal data because the information just isn't there. One of the benefits, though, of using the lower levels of measurement is that you tend to have less restrictive assumptions about what you can do methods-wise. The trade-off is that the data analysis techniques for those kinds of variables tend to also be less sensitive. So you may be more likely to find a signal when you have more information in your outcome. I'm sure most of you, if you've ever interacted with a statistician, the statistician would say, let's say you're collecting age. A lot of researchers like to collect age in categories. So through a survey, for instance, the survey may say, please denote your age. I am between 25 and 34, 35 and 43, you know, classifying subjects into categories. Why the categories? What would be a more efficient, a more meaningful observation to collect when you're surveying individuals in terms of their age? Their age, right? Their actual age. If you decide later that the best way to visualize it in a manuscript or a presentation is through categories, you can always go from more information to less, but you can never go from less information to more. So always err on the side of more information if that information can be collected. Now, there will always be cases, though, where there is no interval or ratio variable to be collected. It has to be interval or ordinal, and that's just the feasibility issue. But if you have the choice, you definitely want to have the higher level of measurement. Briefly, the types of summaries that we tend to use for these data. Nominal and ordinal, we often report frequencies, percentages, and categories. The mode, which is the most frequently occurring response. With the more quantitative data, the interval and ratio, we can actually do more sophisticated things like report the mean and the standard deviation, or a geometric mean and a coefficient of variation. Any questions? Is this making sense? Hopefully it's reiterating some things you've learned in the past. Hopefully I'm not boring you too much, but we have to talk about these things before we talk about the more complex stuff. So how do we graphically describe data? I'm going to breeze through some of this because most of us understand the purpose of graphs. But again, first determine what kind of outcome you have. If you have a discrete qualitative measurement like rank or gender, you typically report that in a table using frequencies. So how many subjects or how much of your sample fell into that particular classification. And then you report the percentages or proportions along with that to describe what the distribution looked like among the levels of the variable. Visually, you would want to use things like bar charts to represent data. This is an example, and I'm not going to go through the whole thing because it will take too long, but it's an example of a survey of almost 500 children looking at whether there was an association between light while they sleep, like use of a night light or a fully lit room, and the incidence of nearsightedness. So it's an observational study. What could be a potential problem with this study? A lurking variable, right? And it turns out there is a lurking variable here. They think that the more light exposure at night a child gets, the more likely they are to have nearsightedness as an adult. One thing that I want to emphasize at this point is that here's a table. It'll take you a couple minutes to read this and really see what's going on, but we could visualize the data in different ways. This is full light, night light, and darkness. And then the high, some, and none classifications have to do with their degree of nearsightedness. So we're seeing patterns here much more quickly than we saw any pattern in the data. And I'm not going to talk about the pattern for the sake of time. But it turns out, as the amount of sleep time light increases, the incidence of myopia is increasing. But because this is an observational study, we're not showing that exposure is causing the condition, because there may be confounding factors. What could be a confounding factor in this kind of a study? Genetics. Children whose parents have issues are more likely to suffer from it themselves, right? If I have visual problems, I could pass that on to my children. It's also possible that if I have visual problems, I'm doing it for my benefit. I'm providing light while my children sleep, either consciously or subconsciously. So that could be a confounding factor, genetics. It could have there could be no real relationship between the light exposure and the outcome. Here's another example of looking at the comparison between nausea and no nausea in subjects who experience nausea as a result of a drug. The emphasis that I want to make here is that here we have the raw frequencies. But visually, it's sort of misleading. When you have unequal sample sizes, it's actually much more effective or meaningful to report percentages rather than frequencies. So you can see the relative distribution of the doses in the two groups. Some other examples, bars and pie charts, tend to represent classification and either the frequency or the percentage within a sample. Interval and ratio variables are continuous. They're quantitative, so you can actually do much more sophisticated things with them. You can show here, this is a histogram of time to death in 100 patients in a study. Very quickly, visually, I can see that it starts at 0 and it goes out to beyond 15. Patients are more likely to die within, let's say, I'm going to guess this is 5 months. And then we have some what we call outliers, some people that are surviving much longer than the typical 5 months. So again, we quickly observe the characteristics from the histogram that we may not get the full picture from if we use numerical summaries. Here's another example of a histogram along with what we call a box plot, and to demonstrate that they really are showing the same sorts of information. The histogram shows you the distribution of weight for 100 subjects in a study. You can see that the average weight is here, and we have likely values here, and we have a couple of unusual observations here. The box plot is doing the same thing. It represents the middle of the data, the typical span of the data, some measure of the range going out to a certain distance, and then outliers through those dots. These kinds of graphical summaries can be very easily computed in most statistical software. Histograms are really good when you have one group. So if you have a single sample study, a histogram is a really good way to visualize it. It's not that great when you have multiple groups. So here we have an example of tooth growth for 2 different supplements at 3 different dose levels. Bless you. That would be very difficult to visualize using like 6 different histograms. But the box plots summarize the relationships not only between dose, but also between dose and supplement for tooth growth pretty quickly. You can see an increasing relationship. So a dose response, right? As my dose increases, my response is increasing. And you can see the 2 different supplements that in general, the supplement that's coded yellow is performing better. It's causing increased tooth growth relative to the green one at the same dose level. So we can visualize that very, very quickly. How do we do the same summaries using numbers. So I would always encourage anyone who's trying to present data to present it using pictures. You need to provide the numbers, but if you don't also provide a picture, it may be very difficult for the audience to quickly grasp the story. So when we describe data, nominal and ordinal measurements, so those are those qualitative, discrete variables, we usually just talk about frequencies and percentages in tables. We really can't talk about averages or variability. We can talk about variability, but it doesn't make as much sense with categorical data as it does with continuous data. With interval and ratio data, they're actually quantitative. We can talk about 3 different aspects because they have so much information in them. We have to talk about what do they tend to look like. Is there a value that they tend toward? That's called the central tendency. A good example of that is the mean. How much do they vary? So how noisy is the data? That's the variability, which represents how scattered the data is around that central value. Larger values of these numbers indicate a much higher scatter or noise in the data. We also want to describe the shape of the distribution. So is it nice and normal? Are there multiple humps? Is it, what does it visually look like? It's important to talk about that. So briefly, central tendency tends to be described with means, medians, and modes. The mode is the most frequently occurring value in the sample, and it may or may not exist. And this is usually best for nominal categorical variables. So on that example of survival time, the mode would be this value, about 3.5 or whatever this bin is, because it's the most frequently occurring value for this distribution. For male and female, male would be the mode. The median is, in essence, the middle value. It's the 50th percentile. It's the point at which the data, the sample that you have, is cut into 2 equal-sized pieces. It's appropriate for ordinal measurements and for skewed interval or ratio measurements because it's not affected by the tails or the extreme values in the distribution. That means it's robust to outlying observations. The reason it's robust is because the way the median is computed, it strips the information from the data. It takes away the raw values. All it does is rank order them and then cut them in half size-wise. So it doesn't take into account values that are very, very large or very, very small. It removes that information. This is an example of its robustness. Suppose we have a set of observations from a sample of size 4. 1, 2, 2, and 4. So the median for this sample would be 2, right? The number 2 would cut this into 2 equal groups. But suppose we accidentally mismeasured the last observation. We record it as 9. What's the median for the wrong data? It's still 2. Right? So it's robust to changes like that. It's robust to tail issues, if you will. So the median will still be located toward the relative, what we'll call center of the data, the most likely values. It's very close to the mode in this case. And again, this is a skewed distribution, so we have to be careful that it's these values here are not affecting the median. The mean is just the average of the variable. It's actually the preferred measure when you have quantitative data, but the data has to be relatively symmetric because it's not robust to issues like outliers or weird behavior in the tails. So again, it is affected by extreme values because unlike the median, which strips away the magnitude of the raw data and rank orders it, it actually takes into account through the formula the magnitude of the size of every observation. So let's go back to that example where we had the original data and a mismeasured observation. In the original data, the median was 2, and the mean is actually very close to that, 2.25. Everyone knows how to compute the mean, right? You add up the observations and divide by the number of observations. But suppose we mismeasured the last observation. What is the median? It's not affected. What happens to the mean? It is pulled toward the tail where that outlying or extreme observation is. So it's actually artificially inflated by outlying observations. It will be affected. This is a good example of showing how the mean is affected by skewness. Skewness usually occurs because we have what looks like could have been a symmetric distribution, but someone came and pulled on a tail and pulled some observations either toward very large values or very small values relative to the normal values in the sample. The mean will naturally follow the tail of the distribution and maybe not be as representative of the average of data like this as the median would be. Variability represents the spread of the data. We can do that in many ways using things like the range, which is the difference between minimum and maximum values, and the standard deviation, which is analogous to the mean. It takes into account the raw data and how much they vary about the mean. Nominal and ordinal data are rarely summarized using variability measures. You really need to have interval or ratio data to talk about things like the range and standard deviation. So the range, you can think of the range as being similar to the median in that it really doesn't, it just looks at the low end of the distribution and the high end. It takes the minimum and maximum values and it computes a distance between the two. The problem with the range, though, is since you're working at the tails, if you have outlying observations, it could make the data look much more dispersed than it actually is. So again, an example of how the range can be artificially inflated. Suppose we have a data set 1, 2, 3, 4, and 10, and I accidentally hit 0 twice when I entered in 10. The range goes from 9 to 99. So it's very, very influenced by extreme values. The interquartile range, though, does the same thing, and it removes that problem. So the distance here is not computed from the minimum and maximum value. It's computed between quartiles. The point at which I have 25% of the data to the left and 25% of the data to the right, sort of truncated off, I compute between Q1, which is the first quartile, and Q3. And you saw this when we demonstrated that box plot. And there it is. So this is Q1. 25% of the data is here, 75% out here. Q3 is the point at which 75% is below and 25% is above. If I look at that range, that's actually probably a better representation of the spread, the overall spread of the data, than going from outlier to outlier in this case. Standard deviation is mathematical. It's analogous, again, to the mean because it represents an average. Only instead of a central tendency, it's talking about the spread of the data around the mean. The standard deviation squared is what we call the variance. We tend to use the standard deviation when we're trying to interpret data rather than the variance because the standard deviation is given in the same units as the data. So if I talk about someone's age, the age of a population, I say they're 54 plus or minus 12 years. That's easier than 12 squared and years squared in terms of just actually being able to interpret the data. And then the third characteristic is the shape. I've got 2 slides for this, and I'll let you guys go. I apologize for going over a little bit. The shape of a distribution is also important because it helps bring things into context. This is a nice normal distribution, that bell-shaped curve. This is a nice skewed distribution. Again, it looks like someone took that curve and stretched out one of the tails. This is a skewed bimodal distribution. Technically, this is the mode, but we have 2 humps. When you see shapes like this, very often it should lead you to think that you actually don't have one population, you're looking at 2. So this could be the quantitative scores on the GRE for arts majors versus science majors. So you have arts majors who are a little bit lower on the GRE. You have the average, and then you have those that are on the higher end of the spectrum. And then you have quantitative scores on the GRE for people who are quantitatively inclined. So they're in general, they have their own distribution, but since you're plotting them together, you really see the two different humps. Lots of different ways to visualize shapes. Lots of different shapes. And again, the shape is important to look at because in addition to determining how you describe the data through the summary statistics, it will be determined how you analyze it as well. If you have symmetric distributions, certain methods will be appropriate. If you have asymmetry, other methods will be appropriate. So in summary, we covered basic concepts like vocabulary and descriptive statistics. Next time, we're going to talk about design and quality of evidence and get a little bit into hypothesis testing. So I encourage you, if you have any questions, I'll stick around. If you have places to run off to, please feel free to go, but you can always email me. Otherwise, I will see you all next time. Thank you.